Good day, dear colleagues. Thank you for having me. I will have a presentation about clinical case that we have in our clinics. I represent Crystal Vision Eye Clinics. We are working 23 years in Russia, and in April we opened a clinic in Bahrain, so we can say proudly that we are part of Gulf region ophthalmology. So I have a conflict of interest, the Strabo mathematical model of strabismus dosage of strabismus surgery that about which I will talk is developed by my teacher and head of Crystal Vision Eye Clinics, Professor Igor Raznorian, and we use it in our clinics for all strabismus surgeries. So we use Strabo care system for all strabismus cases, also for traumatic strabismus cases, and it includes high precision diagnostics, a precise mathematical model of dosage of strabismus surgery, low traumatic technique. We don't use scissors and knives, so we use only radio wave knife surgery, and liquid crystal glasses. So we have a patient who had come with their complaints of diplopia, esotropia, and a limited movement of the left eyes for 2 years that he had after a car crash. And after this car crash, he was in coma in 2 weeks. For detecting the strabismus angle, we use video oculography, and we there have a strabismus angle for with cover OD for 47 degrees and left eye for 23 degrees. And here we can see in this video oculography that when a patient is looking to the right side, his eyes are moving identically. And in the left eye, we see that green point is not moving. This shows the limitation of abduction. And so we had performed an MRI, and we had found very interesting case that he had an atrophy of the lateral medial rectus and hypertrophy of the medium rectal muscle. And we think that it was because of their some problems with the blood supply after this car crash, and this was caused by trauma. So here we see how his eyes was before the first part of surgery. And the first stage of surgery, we had made a deep recession of medium rectal muscle. We use radio wave knife for that. And also we had calculated a dosage of strabismus surgery by our program, where we put individual parameters of the patient's eye as anterior-posterior axis, transversus axis, corneal diameter, and we had information about their dosage of recession that we had to do. Why we do deep recession? Because as you see here in the animation, when we are doing recession before the equator, we had no turning effect of the eye, so we use a deep recession behind the equator. And so here we see their patient's eye after the first stage of the surgery. We have increase in range of movement and decrease in horizontal deviation. By video oculography, we had decrease by in cover OD from 47 degrees to 34, but his vision was also simultaneous and he has double vision. So the second part of our surgery was transposition of inferior and superior rectal muscles to lateral rectal muscle to make it much more stronger. And after the first stage of surgery, we have orthophoria. So as a patient before the car crash has a binocular vision and 100% of visual acuity, he has, in the picture you can see that he has an orthophoria. And in the video oculography, he has degrees with the cover OD 10 degrees, and when we cover left eye, 12 degrees, and binocular vision. So the results of treatment of these patients was orthotrophy, binocular vision, and we restore his movements to the full range. Also, I want to invite you to their international meeting that will be held in Georgia next year for pediatric ophthalmology and strabismus. That will be held by the Association of Ophthalmology and Strabismus and Georgian Pediatric Ophthalmology Strabismus Society in October 2025. Thank you for your attention.
Thank you, Dr. Saya. I have a short question, Doctora, please. We have a short question for your case. For the non-expert, how do you make a difference between a sixth nerve palsy and this patient, and as you mentioned, the traumatic ischemic problem of the muscle?
So for sure, there is some technique for treating their sixth nerve palsy, and this patient was similar, but this patient, as we understand that he has no complaints before the car crash, and everything starts after that, and diplopia, and his esotropia, and limitation of eye movements. We understand that it was connected with their maybe some blood problems with blood supply that he had after that.
But you can also expect to have a sixth nerve palsy after a head trauma, and he was in a coma, this patient. So it might be also a sixth nerve palsy as well.
So yes, maybe, but and we also understand that it can be also caused by this car crash, and so that's why this can be as their sixth nerve palsy, as their problems with the blood supply. It can be like a complicated cause. So there can be two problems in one.
Thank you.
Now, Dr. Yehia, we're going to present a real-life case.
And I want to share with you, I want your reaction. This is a penetrating trauma. Let's recap what we have seen in the different lectures. What test do you think we should do for this patient? This is... What test?
We can have mics for the audience, please. We can have mics for the audience.
We can do it fast so as to be able to see some of the cases. So what test, just anybody comments? Would you do CT, ultrasonography? What test you would do? Okay, how to manage? Should we start with the sclera, cut the iris, then close the cornea? So we should try as much as possible to reposit this, clean it, wash, even with antibiotics, and then reposit this uveal tissue, close the limbus, cornea if there is extension, and then sclera.
Dr. Yehia, can I ask you about this also? If the iris is outside, what's your time limit cut off to cut the iris, clean it, and reposit it?
Actually, I think there is no time limit. So long you can clean whatever you have, even the patient comes after 2 weeks and you see a lot of exudates, if it is not completely damaged, friable, always try to clean it. It will be cleaned and it will be reposited. So if you can save the iris, save it. Yani.
No fear for sympathetic ophthalmia, like we used to teach long time ago, sympathetic ophthalmia in the other eye.
Why?
Why not? Because it's iris, it's inclusion in the wound. Sometimes antibodies happens.
It's extremely rare to have sympathetic ophthalmia, and it can happen after 20 years. And if it happens now, it's very easy to diagnose that there is uveitis in the other eye. You can give steroids. So it's not something to do to prevent sympathetic ophthalmia. It's always better to preserve the iris. And even if you cut it, you will not prevent the occurrence of theoretically, sympathetic ophthalmia. I think we should move with...
Do you think the position of the iris prolapse here doesn't matter for you? It's upper and covered by the upper eyelid or not?
It doesn't matter. You always reposit. Yes, but this as regards prevent infection, but here you want to preserve the uveal tissue. So even if it's posterior in the sclera, reposit the uveal tissue. This is a severe trauma motor accident, car accident case. How to proceed when you see, if this patient comes to you to your outpatient clinic, would you just examine him, or would you be very interested to have general surgery comment and neuro-ophthalmology comment on the status of the patient? It is very important because he might have head injury and starting bleeding, and he can die while you are trying to repair his eye. So you have to clear him from fatal condition and then start to evaluate the condition as it is. You evaluate the orbit, the eyelids, the eye, keeping in mind that you always want to have to restore anatomy, to restore function, to restore cosmesis in this sequence. This is a question, but according to what you have seen, what zone of eye injury is involved here? Is it zone 1, 2, or 3?
We have to see the limbus first.
They have to?
To cross the limbus, we don't see what's going down there.
This is important. If it is reaching the limbus, what zone? 1, 2, 3. 1, zone 1, correct. This is a patient presenting with, he was hammering, and then he came with this subconjunctival hemorrhage with very small, tiny wound and iris defect. So if you don't examine the patient properly, and you think this is the only insult here, and you don't think that under this subconjunctival hemorrhage there might be another place of entry of a foreign body, you will be mistaken. You will regret this after some time. So here we are closing the corneal wound in the rules that we said: deep, predesmate, equal, short if it is in the periphery, and then you will address the subconjunctival hemorrhage. Sometimes the patient comes with extensive subconjunctival hemorrhage. If you have a deep chamber, if you have vitreous hemorrhage, if you think of the history that there is probably a foreign body, you have to explore under a subconjunctival hemorrhage. Open the conjunctiva, it will not hurt the patient. Open the conjunctiva to explore under . So if you have a patient like this coming late of corneal laceration, coming after 2 weeks with this appearance, as you can see, it's infiltrated, the wound is infiltrated, there is complicated cataract, doesn't matter here. But my main concern here is that this wound is not clean. What are the risks and difficulties in these patients? The main risk is infection, endophthalmitis. And the second the main difficulty is going to be to suture the corneal wound. Sometimes the suture will cut through. So you can either postpone the surgery until it's only 1 case.
1 minute, 1 minute, please.
It's either going to cut, so you can do scraping just to know the microbe and then treat the patient, make the cornea better, and then close the wound. So it is very important to think here is a wound that is scleral, corneoscleral laceration, and it has many angles. Where you are going to take the first suture?
2 weeks.
The first suture is the limbus. Where is the second suture, you think?
Center of the cornea.
The angle, this one.
Yes.
So you take the first suture here, because we are saying restore anatomy. The second one, always take the apex of any wounds first to align the edges. Then you can complete the cornea, and then I'm sorry.
Thank
No,
you, Dr. Yehia.
just okay.
Thank you so much.
Thank you very much.